Good evening, friends. Welcome to this Tuesday evening masterclasses and sessions from Yashoda Group of Hospitals. And this has been almost more than 6 years since we started this program and doing. And every time we try to actually ask questions to our fellow colleagues and friends and students to bring some topics for of their interest. And today, we try to bring a topic which has been there for debate for more than many decades. From our medical school days, we have been listening about this debate, and it's ongoing, and it will be never-ending story. But I think to give some clarity and give some balance, we have three very eminent panelists. Dr. Urvi. Dr. Urvi, madam, is a senior consultant and right now she's the director in Aditya Birla Memorial Hospital. So Dr. Urvi has been a good friend of ours, has been a seasoned academician in recent times. Dr. Urvi, thank you for being with us and sparing time to be a part of it.
Thank you.
So we have Dr. Rimita De. Dr. Rimita De has been a part of Ruby General Hospital. She is the department head and a senior consultant there. And she also will be a part of a physician or internist also, along with a critical care consultant. So we are happy and glad, ma'am, to have you on board so that we can see the both sides of you as an intensivist and a critical care specialist, along with what a primary clinician thinks about it. Thank you for being a part of us, ma'am.
Thank you, Dr. Kola. I'm privileged to be a part of this webinar, and hopefully, we'll bring out meaningful discussions in the ongoing debate. Let's see.
We welcome also Dr. Pooja Murthy, ma'am. He has been consultant in the Astor Whitefield Hospital in Bangalore. Ma'am has been a part of many of our academic forums and a good friend of all of us in this part of the world. Dr. Pooja, welcome you on board and thank you for joining us.
Thank you, sir. I think hopefully we have a very fruitful discussion and reach some conclusion because we've not reached any conclusion in all these decades.
So, Dr. Pooja, back to you. As we all know, this debate has been it's old. There's nothing new in this debate. But what do you think? I think when we were students, very few institutions in this country were considered to be closed. And one of the institution is close to your state and your city. Manipal Group of Hospitals, where it was considered as a closed ICUs compared to all many others were called as the open or a semi-closed. So, what is exactly this closed and open ICUs are? What do you think are they?
So, as per the popular definitions and all that, open ICU is generally a ICU where patients are admitted under a primary consultant, and the intensivist or the ICU physician will have an advisory role or a consultant role. So essentially, the decisions usually are mainly by the primary consultant in a rigid way. And coming to closed ICU is an ICU where, the intensivist is in charge of the patient. It will be an intensivist-led ICU, and the major decisions are taken by the intensivist, and the primary consultant will act as a advisory role. There's a flip of the role there. So that's what the gross definition runs through. So, yes, I have also, right now, I'm in Aster, and we also have a closed ICU system in Aster Whitefield. And I worked in Manipal, the age-old closed ICU for almost 7 years before I moved to Aster. So, that's where we are. So, rigidly, I think in the chat, I could see there's a lot of confusion with some people asking that. Is open ICU open to relatives and closed ICU closed to relatives? It's not like that. Open close depends on what the role of each person is. Open is multiple primary
It's
consultants will be in charge of the
not based
patient. Yeah.
it's not based on
And it
the
is not
family
based
visitors.
about family visitations at all.
Family
And
visitors.
yeah, closed ICU is where the intensivist is in charge and the other teams act as advisory roles. So that's where we are.
Ma'am, I will just try to maybe twist a little bit. I don't see right now any ICU is open anymore. I think 90% or maybe more than 90% in at least in the metro cities or in the tertiary care or a corporate care hospital or institution, it is driven by intensivist. But my question will be a little different. It is no more like age-old days where the decisions, all the control is by the primary consultant. The intensivist only used to be a supporting role, putting lines, delivering maybe a airway support and all, but they lead. But the question is, the patient will be under the primary.
Yeah.
There's a difference right now. So what we meant is, if the intensive care is led by a critical care doctor, and all those patients who come to that intensive care unit are under the critical care led doctor, and primary doctors come as a referral team or an advisory team who comes and goes, but the ownership, the responsibility, accountability, everything holds on to the intensive care led. So that was what was been considered as a closed ICU, as we all understand in a more firm way. And open ICUs are considered where all the other primary consultants are allowed to admit their patients. But yes, they only, I think most of our Indian ICUs, if you look at, if you said an example of Aster, Whitefield, or any of our hospitals, where the primary clinicians do visit once, talk to the family about the case, and then they ask us, how is my patient doing, what is the surgery. If you ask me, if you're saying this, majority of the decisions are led by critical care doctor is called closed ICU, then we are already closed.
No, it's
But
essentially
if
the
the
responsibility. I
admits are
think,
taken by the primary consultant and we take the lead, yeah, just I'm trying to make it little more, ma'am. Dr.
I
Pooja,
have a
please go
little
ahead.
lag of network here. Sorry. Can you come again, the last part?
Yeah, even I couldn't hear Dr. Venkat. We couldn't hear the last part of what you
No,
said.
yeah, yeah,
I think your
okay.
voice.
Now I'm clear.
Yes,
Yeah,
yes,
now
yes.
you're better. Yes.
My network is not good. 1 second, I'm trying to probably will change my network. In the meanwhile, Dr. Pooja, I just wanted you to hear me.
Yes, yeah, it's clear now. Yeah.
So I was trying to just say, I will just change my. Yeah, ma'am, what I was just trying to tell you is, as you said, that was the age-old definition which we all used to follow. But if you currently see, most of our ICUs, where a primary team still admits their patients, but majority of the decisions have been taken and round the clock coverage has been given by the critical care team. The primary team may visits the patient once in a day, maybe during the rounds, and talks to us, talks to the family, endorse our plan of care, and then they actually keep the family also into the confidence that the critical care team will take care. Are you telling that this is a closed ICU, or the earlier definition where we used to say, if a patient comes to the ICU, it will be directly admitted under a critical care consultant, and rest of the primary consultants, whoever are supposed to be, or the specialty consultant will come and give their opinion, and then they go away. So is there a difference between these two kind of patterns?
So, yes, I think, see, generally, when we talk about the traditional closed ICU or whatever, it was advisory role by each party. So, if it's a closed ICU, the primary
No,
consultant
no
will give
admissions
advice
of
and
the
all that.
other specialties are allowed. No
Yeah,
admissions of the other
yes.
specialties
But
are allowed.
if
That's what we
legally
told
and
about.
yeah, so in terms of how the hospital functions in the closed ICU system, like example, where I work, any patient who comes to ICU is admitted under critical care team. So I am the owner.
Okay.
I have the ownership of the patient as long as the patient is in ICU. So all
Yes.
patients,
Okay.
it includes medical patients directly coming from ER, or any patient in the ward who's sick who comes to ICU, post-operative patients coming to ICU, all of them the ownership gets transferred to Team Critical Care Medicine. So that's how closed ICU runs generally in Bangalore. But technically, if you have to understand the whole ethos of the definition, it is the intensivist who's driving the decisions, the intensivist who's taking responsibility, the intensivist who is, multitasking in terms of speaking to family, speaking also to primary consultants. So technically, I totally agree with you in terms of all majority of the ICUs right now in our country are kind of closed in the
Driven
real sense. Yeah,
by. Yes. Yeah, perfect, ma'am. So even though the admission remains to be with some of the ICUs in the primary, but it is driven by,
it is
and
driven. Yeah, so it is an intensivist driven ICU, I can say.
yes, and some of you are lucky that you still have that add-on advantage of being transferred to you.
Yeah.
So we will come back to you. How is the other primary consultants feel about it? But before that, Dr. Urvi, do we have any a real rational reason of debating this? Do you think that uh, the the ICUs which are driven by intensive care, and as Dr. Pooja said, the responsibility, accountability has also been immediately transferred to the critical care team once the patient has been transferred to the intensive care. Will it make a difference in the terms of the care, the mortality, the length of stay, the compliance of the bundles, and many other things? Do you think there is a robust evidence which is supporting us, or a reason for this?
Dr. Venkat, first of all, thank you for having a all-women team today. And because I've been part of diversity, equity, inclusivity committee, and we have been always, harping about why should there only be male members in any of the medical scientific panels. So thank you for that. I think you are going to be very popular
I
today.
have the same question when Dr. Kaladar asked me. I said, you never asked me when I had all the male panelists. Why are you asking today? So we have no reason to have one male panelist. We'll have all the women panelists. No, doesn't matter, ma'am.
Fantastic.
And we have so many wise brains, so we can't miss them.
Absolutely. So, coming to your question, there have been some studies where it has been shown, albeit these are all studies coming from the Western world where it's more protocolized and maybe they don't have as much, interpersonal conflicts that we have. I'm not sure, but that is my impression. But it has been shown that closed ICUs definitely have lower mortality. They have better or shorter length of stays. If there is more adherence to treatment protocols, then there is more adherence to continuity of care of that sort. If you ask me my personal opinion, I think the most in the Indian setting or in the region that we have been working now for about for 28 years now in the ICU, what I feel is intensive care led teams. I'm not sure about mortality, but I am very sure about length of stay, and I'm very sure about adherence to treatment protocols and adherence to resuscitation protocols. These definitely are much better when the whole responsibility is shifted to intensive care team rather than to a primary physician or a surgeon who dictates ki, now you only give 2 pints of RL, don't give more fluids or don't give less fluids, because their training comes from lot of what their seniors and their predecessors have done. So that is what I feel. I'm not very sure about the mortality, but that's my personal feeling. I don't have any data to back it up. The Western data definitely says that mortality is definitely lower when it's a closed ICU.
Maybe we need Indian data, as you said. We never had this kind of things.
Yeah.
We had few closed ICUs in, as Dr. Pooja said, and we have previously in Manipal and others. We have many ICUs which are open till intensivist based, maybe play supporting role, but the real challenge will be defining them.
Yes, absolutely.
Driven or
And I think
admission,
that
it will be such an. Ma'am.
yeah, and the question you asked was very true. I mean, what defines a closed ICU? The patient, when the patient is admitted under a critical care consultant, only then it defines a closed ICU. Because everybody else just comes and goes, and you still have the veto power, not just by being friendly to the primary doctors, but because the patient is admitted under you. So I think that is more important. That's where the whole game changes.
If you
If you
ask
don't, if
me,
we, yeah,
maybe
if I can
maybe
add
less
on,
than 1%, less than 1 or 2% of the ICUs right now in India will be in that kind of pattern. What do you think, Dr.
Exactly.
Pooja?
The rest are all,
no, I agree. I agree. I mean, it all depends on how it has been going. I trained in Mumbai, so I worked in an open kind of ICU, as you can say, or maybe an intensivist driven ICU in the ethos of the whole thing. And I've practiced in the last around 10 years in Bangalore in a closed ICU system. So essentially what I realize is majority of the times it doesn't matter unless there is a conflict or some situation like that where uh, us and the primary consultants are totally on a loggerhead, so we are not agreeing to things. And more so, I think lot of rationalization happens, like Dr. Urvi mentioned. Antibiotics is one bone of contention which always happens,
Right.
and whoever the patient is admitted under legally, and even like having a veto power, uh, has the say. So right, and irrational antibiotic use, irrational imaging, blood products, a lot of things. Even studies have
So the
shown that appropriate resource utilization doesn't happen when you do not
final
have
call,
the onus of it. Yeah.
final call will be most of the times an intensive care specialist when it is admitted under him. That's what you mean to say.
Yes,
When
that's what I meant.
conflict.
yeah, it
Uh,
has. You put the pen on the paper, you sign the dotted line, and you say that this patient, any patient who walks through this or wheels in through this door, is admitted under critical care only, and that's when the game will change. Till
Yeah.
the time,
any
it's
information, any other hospitals in Bangalore are following this? Bangalore has been a trendsetter in this, Dr. Pooja. How many hospitals in Bangalore are?
So in
Um,
Bangalore, of course, all the Manipals all follow, if I'm not wrong, because there are a lot, like six or seven Manipals right now. And in Aster, it's Aster Whitefield is one which we follow. So
any such hospitals? I think we don't see such trends in other cities, including in
yeah.
Hyderabad, where majority of our cases, even though the critical care team has its admission rights, and we do admit our share, but not all the cases which transfers to the ICU are admitted under only critical care.
Mhm.
What we have done in our ICUs by default, any case comes to the critical care department or intensive care, will have a co-consultation or a co-consultant. It will be a combined admission along with the primary team.
Yeah, that's how it works in Kolkata as well, right? That
So
any
we do
So,
not have a combined admission here in Bangalore. I mean, at least the place where and in Manipal. So it's admitted under critical care, and there will be a consultation for the other teams. Of course,
and
there are few areas like cardiac unit and neuro units run separately.
so
So
they are a
uh,
specialty ICUs. They are a
yes,
specialty.
they are run by their own teams. So if we go there as advisory, so we go there as a reference if they call us. It's like that. Yeah.
Okay, we'll come back to you. Dr. Rimita, I think we are all more of intensivist driven discussion. So you are a physician too, internist too. So I just wanted to know, families has been attached to my primary team for a long. They have a bonding, they have a trust, they come for them. They want them to see the patient, they want them to actually counsel them, they want our decisions to be conveyed to them, they want to listen from them.
yeah,
And sometimes they feel like their autonomy is lost.
yeah. And
The
if that is
family connect
done,
has been
they're
disconnected.
they're orphaned, right? If that is not done, they feel orphaned, right? They
Yes.
think that in the most difficult times you have left us, right? So how can you have a handover of my patient to somebody else in the most difficult of the time? That is one thing. Like that is the caveat in this whole intensivist driven model, I would say. Otherwise, true that in terms of ICU governance, let me say the administration, the family members, the primary consultants, uh, your colleagues, the junior colleagues, the sisters, they are all happy with the intensivist-led ICU. They're all happy with them because governance has to be the governance in that geographical area has to be done by the intensivist. The primary physician has 30 patients in the OPD, might have 6 endoscopies, might have cath lab procedures. They cannot be with the patient for a long time listening to, seeing to the changes that happens over a period of time, right? So so that part is always led by the intensivist. Everybody is happy about that, but taking, the patient in the taking over of the patient in the most difficult time, sometimes that becomes a problem for the intensivists, the primary physicians, and the family members. That's the whole caveat, I think, in this intensivist.
Yeah. So sometimes the family also feels that my primary team or my doctor knows my parents for almost 20 years. They know the history. They know their what my father wants or a mother wants. The connect they had sometimes may have a possibility of a dealing, and sometimes I also feel that the lost. I'm not sure whether I can call it some kind of insecurity or some kind of disconnect or some kind of losing patient or something. And there is always a discussion related to when it comes to the counseling. As you rightly mentioned that a busy primary clinician spending a good time in ICU is not a common phenomenon. They just quickly come through, they take rounds, they just endorse whatever plan we made and quickly inform the same thing to the family and walk away. And some of the primary clinicians also get into deep rooted, they go to the details and also try to help us also in the specialty areas when it is required. As an intensivist, I have seen many occasions when my specialties came to my rescue when I needed a deep rooted answers when the basic things are not working. My other question is, when they come, they always soothing to the families. They comfort the families. Their counseling is always been in that let us wait and see things are okay, holding on. But we have seen critical care counseling are always been little more protected and maybe defensive. I am not sure. This has been a consistent concerns raised by many of the times in this last 20 years of the concern. Why is this mindset? Are we little more protected than the primary clinicians? What happens, ma'am? You have been internist. Any experience of this sort?
Yeah, because that connect is when you're seeing a patient for 15 years, right? You know that probably 20 ml Dufalac will be more for him in terms of constipation. Do not give 5 ml probably. So I have not seen as an intensivist that 5 ml Dufalac in any of my books, right? But particularly the geriatric age group, they become a little bit different from the other population. And also I think if the specialty is the main concern, now it's very hard to find these days. I tell you, the single organ intensive care patients. So I really do not understand the concept of this organ specific ICUs, because I really find less kind of organ specific ICUs unless there is a procedure involved. There's an operation or a kind of valvuloplasty or things involved. There is no, as people are living longer, by and large, even for a simple thing, there is a multi-organ approach. That person has to be a kind of diabetic, hypertensive, probably going for a CABG. So it becomes a multi-organ. I mean, I call the organ-specific ICUs or a post-operative ICU, the ICU, a medical ICU with a scar, right? So like that. So I do not, that is difficult to understand in terms of organ-specific ICUs. But yes, when a primary physician is seeing a patient for a long time, it is easier for him or her to predict the trend, predict the adversities and developments in that patient. That he might be knowing your patient doesn't tolerate this antibiotic well in terms of diarrhea, or patient may be allergic, and yes, they do have answers that simple sedative, they may cause more sedation in them or less sedation in them. So those are the things where really a physician seeing for a long time would have to contribute in terms of patient care. So that is what the family member says. He understands the trends in my patients. That is where. And in terms of counseling, because we are seeing short time, so we
Yeah,
are trying to make up things shorter period of time and giving the outcomes in that.
so Pooja, how do you manage your clinicians? We all wanted to learn from asked a Whitefield key. Do all the primary clinicians are comfortable with this kind of protocol? They're okay to transfer all their cases whom they are following for 15, 20 years are transferring you. What magic you do in Aster?
So it's never easy, especially it's a new unit, so it's been 3 year old now for us, and it was always a struggle. It was kind of a literal war, you can say, in a funny way. So it is not easy. First of all, you should have a lot of management support to say that you're going to have a closed ICU. So that's the first thing. And the second thing is, I think with time, trust comes. When you save more patients, the onus is too much when the patient comes to you under your title. So the onus is significant, and the trust builds when, you know, uh, patients get better. So it's a, work in progress, I can say. A lot of conflicts
Do you
happen, but
transfer your patient once your patient is done with the
better. We
intensive?
transfer back to the primary, yes,
Okay.
in the ward.
The same primary comes and visits the patient,
Yes,
but it is under you. The moment the patient will be out of ICU, it will be transferred
it
back.
will be
So
transferred back. Yes.
continuity of care remains with
Yeah.
them.
If sometimes we get directly from emergency, there is no tag of a consultant. Whoever is most deservable at that point of time and on call, say there is a patient who comes with acute GE, say, or urosepsis or whatever. So generally we send it under the on-call physician. So whoever is on call that day, it goes to that person. Or if it's been followed up or a old patient of somebody, then we transfer it to them. So it's a lot of work
Dr.
in terms of maintenance. So we have a lot of groups internally. Like we have a group with internal medicine, we have a group with oncosurgery, we have a group with liver team. So it's
Lot
all
of work.
it's
Dr.
a lot of
Pooja, you
maintenance. Yeah.
Dr. Pooja, you triggered a very, very valid, important point, which is beneath the carpet. That is the ownership, the amount of accountability, responsibility is a different league when a patient is legally admitted under you.
Yeah.
This happens to me when a 15, 20 patients are admitted under me in my ICU. The family expect you to be there with all those steps when there are major decisions taken, the criticality, the outcome, everything. So you
Yes.
have worked in both the ICUs when it was open kind of thing or a semi-closed kind of thing in Mumbai, and now you're working in Whitefield in a completely closed ICU. What is the difference of that kind of pressure? I do understand it is managed by the team, but the leads, the seniors must be taking the ownership of the patient's requirements and their expectations. Any difference in that? You
Yeah, a
raised
lot
a
of
very
difference actually. The ownership is significantly different. What I realized in Mumbai is it was kind of a semi-open or whatever. I mean, like you said, few patients were admitted under a particular ICU consultant, trauma, few things like that. So that used to be taken care and spoken to in a way that we do for all patients. But there were other patients who were admitted under the physician. It was a little relaxed, I can say, because the whole point of you had to maintain the patient and you have to protect the patient rather than spend too much time on counseling and making sure that everything is in place. So that difference is there, and whenever ownership comes to you, it is definitely on you. It automatically comes to anybody that you have to be very vigilant. Your team has to be appropriate, well trained, residents, nurses. So all of this becomes streamlined, knowingly or unknowingly. So that is a definite significant difference which I can make out.
So can I
Dr.
add
Urvi.
some?
Yeah,
Yes.
yeah, Dr. Urvi.
So I think Dr. Pooja, she's doing a fantastic job, because what I feel is, and I agree with Dr. Rimita when she said that even post-surgical patients are medicine patients with a scar. And because we are living longer, you don't find a single organ. So I completely agree there with Dr. Rimita that we cannot have a single organ specific ICU, because it never is that way. So even if I get a patient of myasthenia gravis, there will be a whole load of comorbidities or existing morbidities or new morbidities that will add on to it. That is one point. Second point is probably neuro ICU, closed ICU works because if you can rationalize antibiotics and you can put that neuro protocols in place, you actually will get better outcomes. But when we are talking about GI, liver, kidney, medical ICU, and complex surgeries that we are doing, I think the range of coverage and the range of responsibility that we have to handle when we are in a very closed ICU, where patients will walk in under our name, is too huge. And I would call this as an cognitive overload. See, how much ever you read, I'm going to be very frank here, how much ever you read about every organ, there is no way, and with the way the medical specialties are progressing, especially oncology, liver, kidneys, there is no way that we can achieve a specialist standard in that organ if we have to look at this wide range. So, what I feel is if there is a narrow spectrum, a closed ICU definitely works better. But if the spectrum is too wide, it is better to have semi-closed open ICU where you will get a specialist input on a daily basis, maybe even twice or thrice a day kind of a basis. That's my take on this.
Yeah, Dr. Urvi,
Yeah,
I
if
think
I
we
can
have
add a couple of words. Yeah.
Dr. Pooja, I'll come back to you.
Sure,
Dr.
sure.
Urvi, we have a different viewpoints, as you mentioned, and maybe that is the way many of our intensive cares runs. But Dr. Urvi, I will just, before I go to Dr. Pooja, I wanted to ask you, does a intensive care driven ICU or a closed ICU will make the decisions faster? The like the conflicts, the arguments, the waiting period. I don't know whether the protocols, the de-escalation, the escalation, initiation of a CRRT, intubation, maybe, I'm not sure, but I'm just asking you, will a kind of a closed or a completely driven, I will say, intensive care driven strongly, admissions is a difficult question right now, but a driven where the primary team completely puts the trust back to the primary, the intensivist saying ki, these decisions once the patient is in ICU are taken by you, where most of us do the same thing. We convey the information ki these are done, but the decisions are taken, but it happens faster. Do you think a kind of a closed ICU or intensive care driven will have a better chances of taking decisions quicker?
Yes, definitely. If the primary physician tells me that please don't call me in the middle of the night, you do what you have to do, and we'll discuss this patient in the morning. It definitely happens quicker. But then there are physicians who
Resource.
say, हर घंटे में phone करो. Then it is tough because if that intensivist is busy managing a patient, the intensivist does not have the time to keep informing what has happened in last 1 hour, then in the subsequent hour, and then in the subsequent hour. So I agree that intensive care led you.
Resource utilization happens in a better way in a closed ICU. Resource utilization, you don't have to call every time. Uh,
Absolutely. So resource utilization, quicker decisions, maybe even correct decisions, and the amount of brain space and mental space that is lost when you are trying to call n number of people, that can be used to focus on patient care delivery.
Okay, that's the point. And as you rightly mentioned, in the recent time when we actually did a webinar with a senior leadership in the ISCCM who actually had experience both in India and Western countries regarding the this kind of key single organ expertise in intensive care versus a multi-organ expertise in intensive care. As you rightly mentioned, all of them gave an opinion that whenever we say a neurocritical care specialist or a cardiac critical care specialist or something like that, 50% of the time should be a general critical care. Maybe the rest of the part they can be trained in a specialized area where they need an extra focus in or extra depth in that area. But general critical care is a mandatory for most of them. That's what everybody feels, and all of you also agreed ki, the patient is a patient. It cannot be only one organ, the other organ. The patient may have that particular organ as a major effect, but the patient can land into the other organs in no time in many of us, which we see. I'll come to Dr. Pooja. Dr. Rimita, we are talking about a very few centers in the metros in the quaternary care, where I think we have a luxury of having a director, a critical care clinicians, we have DM, DRNBs and all this. It's not true in the tier 2 cities, district hospitals, and even towns, where there is a challenge at this point of time. Also, a qualified critical care team member is not available, and we still rely on our anesthesia colleagues or somebody from the OT coming and helping, or a pulmonology colleague coming and helping. So it's not easy to actually probably drive some kind of these kind of policy making without looking at this many aspects across the resource limitation. What is your take in those kind of situation, Dr. Imita, where we still rely on those kind of mix or a hybrid models?
Yeah, I think, hybrid models has to be the answer right now in our country, because yes, there are still a lack of intensivists in the tier 2 cities. Yes, you are correct. And second, that what we feel that it's a basic human intention, that if you close the door in front of a person, he tends to break it open. I mean, that's so basic human conscience. So don't close it. Keep it open. So and focus on your parts, right? I just want to share just an incidence, that a patient of pancreatitis admitted under in the ICU, admitted under a gastroenterologist, and the second third day he starts tolerating feeds. Now the patient also is diabetic and has a stent. He has there is a PTC done 5 years back. And at day 3, when he tolerates feed, the gastroenterologist is discussing with the family relatives कि मेरे तरफ से तो ठीक है, he has started tolerating feeds and the abdomen is softer. Would you believe that at that point of time he was having an atrial fibrillation with a heart rate of 154 per minute, right? And the blood pressure was 106/70, and he was a patient of pancreatitis. So there are a lot of things involved in critical care. So of course, when I'm talking about the expertise of the field, the things get diluted. So it's as if when you admit under a specialty, as if that organ is admitted under him only, and the whole of the other organs are admitted under somebody else, right? So that is again the place of an intensivist. You can't spare an intensivist. The intensivist has to be there. The primary has to be there. I think my take is like that. And of course, depending on the number of things in tier 2 cities, I think hybrid model has to be there in intensive care right now in our country.
So I think one of very senior teacher of all of us in the field of cardiology once told me that this is nothing but a fragmentation of medicine, where the vision is getting too tubular when we actually create too much of super specialties or super specialist, where we only talk about a single organ and we forget the our core branch of internal medicine, where all organs interlinked. The integrating the holistic approach of as a patient is been sometimes missing, and I'm sure many of our intensive care specialists may be facing the same problem as you said. My system, I feel, is okay as far
Yeah.
as I am concerned. Your critical care, I will come back and tell you about other specialties. And most of the times this critical care specialist will be stitching this all organs together and trying to give them some kind of a, and in the process he becomes this bad boy saying ki, so many things you are telling about our patients problems, this other doctor said is fairly okay, going on well. Not uncommon. I most often see this kind of situations in many of our situations. Dr. Pooja ma'am.
Yeah, please tell me, sir.
Yeah, so we were just discussing, we wanted different facets. We were trying to request Dr. Ima ma'am to talk about a physician side of it, and Dr. Urvi ma'am from an maybe a open or a semi-closed. From your side, you wanted to make a point during that point. Like, uh,
So, essentially, see, what I feel is, I mean, just to put everything into perspective, a patient of a gastroenterologist admitted in the ward will be not admitted under cardiologist. A patient of a cardiologist admitted in the ward will not be admitted under say a urologist. Similarly, patients in the ICU, and when we are a super specialty unit right now, we are running DRNB super specialty courses. A patient will be sick enough with multi-organ problems or, major life-threatening concerns, which are the priority. And for that reason, if a patient is in ICU, it is always best handled and admitted under critical care physician who definitely will not close the doors or lock it. We used to sometimes closed ICU is a system which generally originates from Australia, if I'm not wrong. So, a few of our colleagues who are trained in Australia, we used to just say you can't close the door or latch the door of the ICU. It has to be a collaboration between the primary physician or a cross consultation with some other doctors along with us, but we will be in the driver's seat trying to, lead the show. So all of it, definitely, we are not looking at just to satisfy the primary consultant or the family's expectations. We are trying to put the patient's safety, patient's, time is money in the ICU. So, the way we intervene or the rapidity with which actions are taken, decisions are taken, resource utilization, the unit functioning cohesively, including the nurses, and there will be one sole person or one team which will be responsible and answerable to the entire lot of these nurses and doctors, which will make the whole system very efficient. So outcomes will be better, much more. Many studies, meta-analysis have given lot of evidence proving beyond doubt that, ICU length of stay, sometimes mortality, all these things are much better in a closed unit. And how we balance the, the communication with the primary consultant and the family, I think, is an art which we have to learn as we move
So I
forward.
will ask a provocative question here. Does egos play a role?
Oh,
Yes, all the
I,
time.
un- I understand closed ICU saves life, open ICU saves egos. Does does you handle egos? Yeah, how do you handle egos? We wanted to learn from you.
All the time, all the time. We'll do it all the time. So I
So,
think that, like I said, with time, what happens when the responsibility of a sick patient doesn't lie with you as a primary consultant, and you're just playing your role as a consultant in the ICU advisory role rather than taking the whole ownership, you also give ample time to your specialty. So if you see a gastroenterologist will be very busy with procedures, OPD patients and all. They will not be able to give time to a patient who is with pancreatitis with multi-organ failure. They can't visit the patient 5 times a day, giving inputs, talking to the family. So the entire onus, if it is admitted under critical care physician and you are giving an advisory role, in fact, your load becomes better. That is how ultimately the primary physicians understand.
I would like to add,
yeah, yeah,
like,
absolutely. Ma'am, I just wanted to ask you, uh, there are exceptions. I do have a few of my primary clinicians who spend hours together when a sick patient is there, making a multidepartmental team meeting, ensuring that no stone unturned to make a patient better. But on an average, because of their load in the OPD procedures and other things, many of the primary consultant are not able to spend maybe not more than 15 minutes or half an hour. I will be probably in a little liberal side. So what is your take, Dr. Rimita? What is the general under clinicians time spent for a critically ill patient in an ICU?
yeah, that's what I said. Because most of the wise men I would do, or wise women would do, is if you are a primary consultant and somebody able with proper education is taking care of your patient
They are
to
ready
make
to have.
it better in a kind of kind of guideline based direction where you are legally safe, and he takes the bad part as well, right? So when he worsens, he goes and counsels the family, takes decisions, and if your patient gets better, comes back to you, what else can you expect as a primary
Exactly.
from your
That's true.
give it to them? Come on,
If,
man.
if you
So
can if you can sell this, if you can
yeah,
sell this, I think there is nothing like this. As
yeah.
Dr. Pooja
So
said,
most of the
he
wise women, they just leave it. They just introduce us. See, this is our intensive care colleague, and I'm going to OPD. That's it.
It
Yeah.
happens. It happens with few of our clinicians. It happens, and the autonomy comes with an accountability.
Yeah.
Autonomy comes with an accountability. If we take the accountability and we actually own the patient and do everything, most of the times the primary clinicians comes and tells you that to the family that this is the guy or this is the team looking after your patient.
Right.
Even though the patient is admitted under them, they are the people who will be counseling you. They are the people who will be telling you what to do. I will be probably coming to talk to you and visit you, but the decisions will be taken by them. And this is one of the way. So the probably that is only happening when you take that accountability ownership
Yes.
from the aspects of it, and the primary consultant have a trust already rapport built to you, and they know that you are the person or you are the team which actually making the difference in life and death, and their lives become very easy.
Yeah.
Nowadays, most of our senior clinicians don't want to get a calls in the middle of the night when they have nothing to offer to probably advise or guide the middle of the night. So they probably will not be willing, or rightly so also. Dr. Urvi, what is your take on that?
Yeah, so I agree with Dr. Rimita and also Dr. Pooja, because if you are ready to take accountability, the consultants will back off, and that has been my experience too. Now, may I just say, probably I am older than Dr. Pooja and Dr. Rimita, so I have seen the old time consultants, and the size of egos that they came with, and the newer generation, or probably those who are passing out in last 15 years. Things have drastically changed, and the newer consultants are much more open to suggestions. They are more open to saying
They are
कि ठीक
accommodating.
है आप काम करो. They are open to giving away the responsibility. They are saying ठीक है, I am an OPD, I have a lineup of 30 patients. If you need me, you call me. So that has definitely changed. There has been a paradigm shift there. And I'm very happy with the way it has moved, because it becomes a very shared kind of a responsibility. Obviously we inform those primary physicians on a timely basis of what is happening, so that they are not left in a lurch. Some family member goes there and says कि हमारे patient के साथ क्या हो रहा है, and that primary physician, poor fellow or poor lady, wouldn't know exactly what went wrong in the ICU. So that kind of a timely briefing is always given, and it helps. I mean, I think it's more like a marriage, the intensive care team versus the primary physicians.
Dr.
And
Pooja, there are interesting questions to you. I'll come back to you, Dr. Urvi.
that marriage has to work.
Yeah. So, which is most cost effective, open or a closed ICU? I'm asking you because you are now, you have seen both ICUs.
Um, Cost effective wise, I think none of them are cost effective nowadays. All are expensive.
It all depends on your organizational packages or bills, not in the open or closed.
But technically, if you see some studies and all, even though they say, you need a lot of human resource for running a closed ICU,
Yeah.
like traditionally, open ICUs never had a nighttime intensivist and all that. But a lot of things are saved for the patient. Unnecessary antibiotics, unnecessary blood products, unnecessary lab investigations. So definitely, as per studies, a closed ICU is more cost effective.
Okay. There is another
And
controversial,
unnecessary references also.
controversial question to you. Which is a better revenue model? I will again say it is for the intensivist and also for the hospital and for the patient.
So we do not deal with the revenue model in our hospital, so it's difficult for us to comment on this. But in some setups, I think closed ICU, the part is shared. I think everywhere it is the same. Either it is admitted under primary or not, the ICU will get its share of consultations and procedures and also that's how it's going to be.
Any issues with insurance and corporate patients when the
Not
journey
at
of
all.
initial admission and switch to another department in the later half?
No, no, not at all. We never had any issue like that.
The same with us also. I think the
Yeah.
transfer happens, and there is a change in the information need to be carried to the corporate
Yes.
so that's what they did. I think we had an interesting, wonderful discussion. What probably I will summarize and take all of you is we have seen different sides of it. Over a time, in the last maybe 2 3 decades, we have seen the changes. The reasons maybe there is a structured training. There are very, I think, well trained, knowledgeable students who are joining this branch, and they have been full time in the critical care, which was not there 30 years back. Now, these are all guys who actually spent 3 years in DM or DRNB or a couple of years as a IFCCM or a IDCCM students, and they are working in intensive care with a robust training and structured training in different organizations. And they come, and when they actually develop the trust rapport and that bonding with the primary consultant, and they know their patients has been taken care in a best possible way in the hands of a critical care guy. Most of the times they hand over their patient, and probably they just visit as a part of it. So whether it is a patient is admitted under a critical care consultant, or it is driven by a critical care consultant where other consultants are also been allowed to admit. Now I think we are seeing a future where it is driven mostly by the critical care fraternity taking the accountability, the responsibility, the ownership of the patient's outcomes, patient's well-being, and the patient decision. I think that will make our all primary teams to believe us, trust us, and give that extra edge, because they will be happy when their patients are getting the best of the care, and at the end of the day they've been transferred back to them in a happier way. So with this I will wanted to take the final comments on this from Dr. Rimita De. Ma'am, back to you. We understand
Yes.
you played both roles today and tried to give us some inputs on both this, ma'am.
Yeah, I think hybrid model is the best way, because I agree with Dr. Urvi that howsoever trained as organ specialist we are in specific domains of organ, we can't match the specialist, right? So if the situation warrants organ specific person, he has to be with us. I think that's one thing, and that's the reason I would say ki hybrid model probably yes. Still now. I would be advocating the hybrid model for intensive care, where kind of a co consultation, the way you have in Hyderabad and the way we have in West Bengal. I think that probably is the best model for me.
So it's not about open or closed, it's about collaborative teamwork, doing the best for the patient. And we all believe it has to be driven by some lead team member in the intensive care unit who can actually take advices and drive. Otherwise,
Yeah.
again, it will get diluted. That's what all of us are moving towards.
And you need intensivist for the governance, I told you, because governance at all the levels in terms of policies, in terms of protocols, in terms of implementation, the bundles, the antibiotics, nutrition, sedation, vacation,
The
taking the patient.
governance will still on to the intensive care lead who actually governs the ICU. That's what you meant.
Yes,
Okay, ma'am.
yes.
Dr. Urvi, any take-home points? You had a balanced view on both sides. How do you go about, and what is your take to the audience?
Yeah, no, so I still agree with I agree with Dr. Rimita, and I feel the hybrid way is the way forward, because we are not just because collaborative teamwork is the best way, but because we are going to see more and more complex medical situations in our ICU. We are living longer, and infectious diseases, even though we say there are MDROs, but we are also seeing a lot more lifestyle based diseases. So if we are going to do that, and then we are going to need all the specialists here. So it is not just for ego or who should lead. It is for, I think, sanity as well. So you want to sleep peacefully at night. Every specialist has made a comment, and everything is being done for the patient because of the sheer complexity of the patients that come to us.
Dr. Pooja, we are impressed, and we are all what you say in, um, uh, carried away by the work you are doing there. And sometimes I think these kind of information makes all of us also feel good. But what is your take home? You had an opportunity to work in this. So whenever there is an opportunity, we still can carry this. What is your take home?
Yeah, see, I don't agree with a totally open or a totally closed. I would say a intensivist-led or driven ICU, along with co-consultations and input from specialties, and keeping patient outcome and maximum benefit to the patient and the protocols and everything to be put into place is the way forward. You can either,
Perfect, ma'am.
yeah, that is-
Perfect. I think we sometimes may have a complexity, but we cannot demand respect. It has to be given when we actually deliver, and that's what I have seen. When you actually stand beside a patient, you deliver the care, you make a difference to the patient. Automatically, your consultants will walk down to you to thank you, and that's how things happen. And we had a wonderful discussion. We had more than hundreds of participants, and these are all been be live for the next of the time in both YouTube and Facebook. And thank all of you for sparing your time, being with us in the evening, and a wonderful learning experience to me also from all of you from a different angle, different perspective. Thank you so much for being a part of this discussion, and I thank all the participants also for being a part of it.
Thank you,
Thank
sir.
you
Thank
so
you.
much. Thank you
Thank
so
you.
much, everybody.
And I thank all the participants, and I conclude the session. Thank you so much.
Thank you.
Thank you.